We shall start, sir. Uh, so, good afternoon, all. Everybody is able to hear me? All the attendees? Yeah. So, let us start this session and by introducing Dr. Ganapathy to all of you. Dr. Ganapathy is director of Apollo Telemedicine Networking Foundation, and he's also the director of Apollo Telehealth Services, and he's also the emeritus professor of Dr. MGR Medical University, Tamil Nadu. By specialty, Dr. Ganapathy is an MS in neurosurgery, and he has also received his PhD in neurosurgery from Madras University. And he is the first in Asia to start clinical telemedicine. Uh, Today, Dr. Ganapathy will be speaking on demystifying new telemedicine practice guidelines and deployment of telehealth in managing COVID-19. Uh, Dr. Ganapathy will be focusing more on managing COVID-19 from a technology perspective. I now hand over the session to Dr. Ganapathy. Dr. Ganapathy, please take over this session and start.
Thank you, Srinivas. At the outset, I wish to thank Medvarsity for giving me this opportunity to create the much needed awareness on two topics. My lecture is going to be divided into two parts. The first one will be to demystify. Honestly, I don't think there is anything mysterious about it, but nevertheless, the recently notified telemedicine practice guidelines. The second part of my talk will be how we can use telehealth, particularly in the management of COVID-19. Contrary to a general erroneous misconception, pandemics are not that rare. The very word quarantine came in 1348, when 40 days was the time allotted in 1348 by the city of Venice to isolate people. 102 years ago, we had the Spanish influenza, where again people were isolated. The only difference between the pandemics then and the pandemic today is the fact that technology is being used like never ever before. Why is the whole world stressing on telemedicine and telehealth? That is because we are in a peculiar situation where we do not want hospitals to be overcrowded. We are looking at a hospital without beds, literally speaking. So we want to take the healthcare providers to your house, to wherever you are, virtually. Over the last 2 months, we have learned very badly that many hospitals, including several in Mumbai, Thiruvananthapuram, and other places, where hospitals have to be closed because 1 or 2 healthcare providers were infected with the coronavirus. Imagine what will happen if a significant part of the healthcare providers are affected. More than that, the risk of catching the infection is much more when you go to the hospital. However, one thing which all of us forget in a pandemic situation, nothing prevents a person from getting a heart attack, from getting acute appendicitis, from getting a convulsion, headache, backache, and what have you. And therefore, telemedicine is particularly essential nowadays to provide health care outside the COVID-19 situation. Ladies and gentlemen, I foresee that this is going to be the new normal. And years after the COVID-19 becomes history, what is going to happen is this is unfortunately resulted in the acceleration of the process of telemedicine, which many of us have been working for the last 2 decades. The World Health Organization, the CDC, and almost all the 185 countries which are today affected with COVID-19 are strongly advocating telemedicine. China, Hong Kong, Australia, to name a few countries. Trump has allocated $500 million exclusively for the use of telemedicine just to deal with the coronavirus pandemic. Now, a recent headline in one of the British papers said, telemedicine arrives in the UK. 10 years of change in 1 week. What the United Kingdom could not achieve in the area of telemedicine for 10 years, the last 1 week these changes have taken place. Those of us who have been advocating telemedicine for 2 decades, we did it for very simple reasons. It increases your access to care, reduces time taken in transportation, is cost effective, and most important, the urban-rural health divide is bridged completely. Honestly, we never thought of telemedicine to that we could catch a new illness by going to a hospital, but this is the latest indication for the deployment of telemedicine. Now, I just, before I go into the legalities, because some of you may not be totally familiar with telemedicine, I want to spend a minute or two on what exactly is telemedicine. Now, telemedicine is basically converting manual records. The record could be a physical examination, the record could be a history taking, the record could be a CT image, laboratory investigations, and what have you, basically converting them to a digital component. Now, obviously, depending on what is to be converted, the bandwidth required can be from very low to extremely high bandwidth. In the last 1 week, you would have seen in all the media, the print media, the digital media, everybody has woken up from a slumber. And there are hundreds, if not thousands, of articles in all the languages saying that doctors are now ready to offer free teleconsultation. Now, what we need to understand is that there are some rules and regulations which we must be familiar with. I personally know at least 50 to 60 hospitals which have put up advertisements like this all over the country. Now, it is very essential. Now, before I go into the legal aspect, you can even today do a clinical evaluation remotely from wherever you are. After all of us, even the non-specialists, we know that COVID-19 essentially involves having fever, having a sore throat, cough, a running nose, and so on. As you can see from this slide, today we can monitor somebody's temperature remotely. Even the relative of a so-called afflicted patient, all that he needs to do is to focus a bright torch, and I, sitting hundreds or thousands of miles away, can look into the interior of the throat, into the interior of the ear, and so on. Already, robots have been deployed in other countries which actually take swabs. A robot takes swabs under the supervision of a human. In Madras alone, in Stanley Medical College, and in other institutions in Tamil Nadu, robots have already been deployed in the area of COVID-19. Bluetooth-enabled stethoscope. Today, it is very, very simple to transmit an audio file. I would not like to diagnose pneumonia when both the lungs have the chest X-ray is obvious. I would like to pick up Rals and Ronka. Can. And believe me, I can do this even if I'm thousands of miles away. Pulse oximeter, oxygenation. We have heard of the Prime Minister of UK being hospitalized in an ICU purely because to monitor his oxygen saturation and ensure that he gets adequate oxygenation. A 12-lead ECG, even a pocket ultrasound. This may not be relevant under the COVID-19, but it is certainly relevant today when a person with an acute abdomen or a lump in the abdomen may not be able to go to a hospital. So these are all peripheral medical devices which have been used for several decades, even in India. Now, I just want to spend 2 minutes on summarizing what exactly is telemedicine. Telemedicine involves, obviously, in my generation, we used to call them doctors. Today, we call them healthcare providers. We used to call them patients. Today, we call them beneficiaries. Today, you have hardware, software, connectivity, acquisition of data, storage of data, retrieval of data, display of this data. Now, this cannot happen overnight. You're not born to know how to practice telemedicine. Training is absolutely essential. And in a country as large as India, we need standards, technical standards, clinical standards. We have to take into account professional negligence if it occurs. Customization, it has to be cost effective. One size does not fit all. Every telemedicine unit has to be customized to suit the specific requirement. Again, ladies and gentlemen, I would like to repeat again and again that a project, unless it is revenue generating, will not be self-sustaining. Philanthropy at the best can initiate the process, but we have learned very hard over the last 2 decades that we need to be future ready, and there has to be a component of revenue in this. Of course, for the next couple of months, all of us are not looking at revenue at all. Now, let's go back to the main theme of this talk. 25th March to me is a red letter day. Another red letter day was 24th March 2000, when the world's first VSAT-enabled village hospital was commissioned in Aruganda by Bill Clinton, the then President of the United States. Exactly 20 years and 1 day later, the Board of Governors, in supervision of the Medical Council of India, notified an amendment to the Indian Medical Council Act. Some of us from the Telemedicine Society of India have been working very hard for several years to achieve this. But what to me is absolutely fascinating is, within 10 days of the initial notification, just 2 days ago, the MCI has again put up on their website frequently asked questions, and almost 10 pages, more than 30 to 40 questions have been put up and answers have been given, all within a week. This is something amazing. It only shows the importance which the government is giving. Now, there have been concerns. Several people have asked me, they are saying, look, this is all right, but this is for the COVID-19. Once it is denotified, the virus goes away, then what happens? I would like to reassure every single person here that this act is not, I repeat, not notified either under the Epidemic Diseases Act of 1897 or even the Disaster Management Act of 2005. It is an amendment to the existing Medical Council of India Act. Ladies and gentlemen, it is here to stay. Telehealth or remote healthcare is going to be the new normal. Again, another advantage with newcomers in telemedicine have got is both these acts unambiguously state that no suit or any legal proceeding can lie against any person for anything done or in good faith intended to be done under this act, which means that if you have genuinely made a mistake, it is only a procedural lapse while trying to diagnose a COVID-19 or something like that. Even if something wrong as goes, you are exempted, you are indemnified from any action being taken against you, because today the Epidemic Diseases Act and the Disaster Management Act have been notified. So this is an extra protection. Please remember that the Telemedicine Act was passed literally as an emergency, primarily to take care of the pandemic situation. And I want to reassure you with all the emphasis at my command that even if inadvertently a mistake is made, action cannot be taken against you so long it is not a gross error of negligence. Errors of judgment are always allowed. Now, 3.3.1 is a specific notification of the paragraph. I've already told you the Indian Medical Council Professional Code of Conduct, which gives statutory support and so on. Now, let's go to the next slide. You see here, I have highlighted it in yellow, shall be permissible. Teleconsultation shall be permissible in accordance with the Telemedicine Practice Guidelines. In other words, this is not a guideline in the simplistic sense of the word. It is law, it has been notified, it is an amendment, and it will be published as an e-gazette very soon, but it's already has the enforcement of law. Now, telemedicine is to enhance health services and access to everyone in India. It doesn't matter whether you're registered under the Tamil Nadu Medical Council or the Karnataka Medical Council, so long as the doctor and the patient are physically somewhere within the Indian province, you are eligible to give teleconsultation. The guidelines are still not clear whether a doctor physically based in India can give a consultation to a patient outside India, or whether we can take a teleconsultation from a doctor outside India. The law is still not clear. We have noted down all this, and I'm sure there will be amendments and modifications, etc., as time passes. Now, something else, most traditionally people have been criticizing the government for decades. Now, just look at this. On 24th of March, a document was sent by the Board of Governors, MCI, to the Ministry of Health. And within 12 hours, the ministry has notified it. Within 12 hours, a paper has been approved and this has become law. So this very clearly indicates how serious the authorities are in the deployment of telehealth. Now, I've already mentioned that this is not pandemic specific. It is here to stay. Now, it is extremely doctor friendly compared to other countries. I have gone through the notifications issued by many countries from all over the world. Malaysia was the first country to enact a Telehealth Act as early as 1997. They have mentioned that a doctor who violates some of the notifications in the Act can be imprisoned up to 5 years. Abu Dhabi has passed a stringent law. No citizen of Abu Dhabi can legally even get a teleconsultation from any doctor anywhere in the world unless that doctor is registered with the Abu Dhabi Health Authority, and so on and so forth. The Government of India notifications are extremely doctor friendly. Of course, a lot of tweaking has to be made, but I'm sure this is going to happen during the next few months. Now, let's go into the details, particularly how it's going to affect each one of us. Now, patient consent for teleconsultation is implied if the patient initiates the teleconsultation. When a patient comes to me for a face-to-face consultation, I do not. Now, of course, some hospitals may, but as an individual clinics, a doctor normally does not take a consultation for a consent form for a consultation. The same thing applies in any form of teleconsultation, provided the patient has initiated the request for a teleconsult. An explicit consent, patient consent, is needed only if a health worker. Now, we are looking at a situation, particularly in a pandemic situation, where an ASHA, a health worker, a nurse, a paramedic, anybody could initiate a teleconsultation. I think this is fantastic. Many countries do not even talk about this, but Indian rules now say that a teleconsultant is legally allowed to get the information, process the information provided by an ASHA, a nurse, another registered medical practitioner, or even a caregiver. I remember the dozens and dozens of times when I was wondering to myself whether what I'm doing was right or wrong. There are so many situations where the son or the wife or the daughter or somebody with all the information available wants to consult you, but the patient is physically not in a position to come in front of a video camera or even to be brought to the nearest telemedicine center. The law at present allows it. Of course, you need an explicit patient consent form. Again, this is very simple. It is not, and the guidelines emphasize this again and again. Please do not be paranoid about getting all this. Don't do things just to protect yourself. I wish to emphasize again and again that you need to do anything and everything in the interest of the patient. The interest of the patient is primary, secondary, tertiary, and quaternary. Everything else becomes absolutely irrelevant. Now, what are the types of consultation? It can be a first consult. Doctors until recently said, we will not do a teleconsultation for a patient whom we have not seen physically before. The law now allows you to do it. Follow-up is defined as any consultation or second or third or fourth consultation repeated within a period of 6 months. If you have not seen a patient physically for a period of 6 months, the law says you need to do a physical re-examination of the patient. This is absolutely correct from a medical point of view. Again, when we talk about managing a patient, when a patient comes to me face to face, the prescription part of it is secondary. All of us, particularly the older doctors, we spend time listening to the patient, advising the patient. In other words, health education, counseling, not only of the patient, but that of the family is as important or more important than medication. So all this is allowed. So the types of teleconsultation I have already mentioned. The first 10 to 12 years, maybe even 15 years, from 2000 to 2015, I've given hundreds of lectures. And in every lecture, somebody would ask me about emergency. And now I feel ashamed, but I have shown so many slides which said at that point of time, a teleconsultation by definition excludes emergencies. And if it is an emergency, it cannot be a teleconsultation. Now I eat my words. My own colleagues have done wonderful work in the last 4 or 5 years. Today, we run the world's largest 24/7 tele-emergency center at 14,000 feet height in the Himalayas. We have done more than 1,200 teleconsults. We did all this without official legal sanction, purely because we argued that everything is being done in the patient's interest. There's nothing mala fide. There is absolutely no other reason why we are providing this. Today, the law allows you to give an emergency teleconsult. Again, ladies and gentlemen, you've got to use your common sense. Most of us may not be in a position to actually carry out the advice which we give. Therefore, an emergency should be interpreted as an emergency. It is actually a sophisticated form of teletriage. You tell the patient this chest pain could be a myocardial infarction. You always err on the side of caution and tell him you must go to the nearest hospital, get an ECG done, or actually even better, don't go to a place where only an ECG can be done. Go to a place where thrombolysis can be initiated. This is what is expected out of you. When you see a chest pain, don't say get an ECG done. No, what is the point in having an ECG and wasting valuable time unless you follow it up with thrombolysis? So I would rather refer a patient to a thrombolytic center 2 hours away. That's more judgment rather than getting an ECG done immediately. So at the end of the day, it's all about clinical judgment, clinical judgment. Now, there are certain norms to be followed when you do a teleconsultation. I have no idea who the patient is. Therefore, it may be extremely rare, but it's not impossible. You must satisfy yourself that the person whom you are talking to, whom you are virtually doing an examination, is actually the patient being referred or for whom the consultation is sought, and not a relative and not a healthcare giver. Similarly, the patient at the other end has a right to know whether you are the actual doctor, whether you have the credentials. When a patient physically comes to a doctor's consulting room, it's unlikely that there will be an impersonation. But it's so easy to impersonate a doctor when you're other end of a camera. Thirdly, and most important, the doctor should maintain patient records of teleconsultation. This is my plea, that don't wait till the very end. Don't wait till the government forces you. It is high time every one of us, it's not as difficult as you think it is. It's high time every one of us starts adopting EHR, or at least an EMR, an electronic medical record. Today, there are dozens of vendors. All this can easily be made available in a smartphone, in a tablet, in a laptop, in a desktop. It can be stored in the cloud, extremely user-friendly. And that way, storage of data, documentation of data becomes extremely simple. You may think I made a typographical error in the last line of this slide. Clinical judgment has been repeated 3 times. Ladies and gentlemen, it is not a typographical error. The more you use technology, the more is a necessity for clinical judgment. I'm just going to show you 2 examples which will indicate to you how telemedicine has to be used very, very judiciously. There are limitations of telemedicine. Maybe there are 1 or 2 disadvantages also. Now, here is a patient. I'm a neurosurgeon by training. I've seen tens of thousands of head injuries in the preceding 45 years. Now, here is a patient who head injury sequelae in a small little town. Now, the relatives came to me and wanted some treatment. I refused. I said, look, unless I know about the patient, I can't. And to my utter surprise and very pleasant surprise, the relative said, sir, can I show him on your phone? And then an ordinary phone, not even a high-level smartphone, an entry-level ordinary phone. He had already stored so many photographs on his phone. He showed me the patient with a Ryle's tube. That gave me some idea. But again, I was not happy. He said, my brother is there and other relatives are there. Please spare a few minutes. I'll ask them to call you on video mode. I said, fine. And you can see here, in a small little town with an ordinary internet, and I don't think they had very high bandwidth and all that, I was able to do a detailed neurological examination. So this is very important. Now, here is a patient from Dubai, a young 12-year-old boy who presented to me on a tele-examination. Now, most people with convulsions do not have, I repeat, 90% of those with convulsions do not have a neurological deficit. Can you play this video, Srinivas? It's at your end. Srinivas? Oh, I'm sorry, it's my mistake. I should have loaded the video. Okay. So this boy had no neurological deficit. The patient gave me a description, the relatives gave me a description which fitted in with a seizure, but I was very reluctant to brand him as a seizure. Now, please remember, just as it is important not to make a wrong diagnosis, it is equally important that just as it is important not to miss a diagnosis, it is equally important not to make a wrong diagnosis. So I insisted on a video, and a couple of days later, through an ordinary mobile phone, they sent me this video. I'm really sorry. I think he's not able to hear me. This would have shown you a video of a person with a classical seizure. In other words, even though I'm a very senior neurosurgeon, I refuse to give an opinion without seeing the attack myself, without seeing the seizure myself. Nothing will happen if the boy is without anticonvulsants for a couple of days. So this is what I mean by clinical judgment. Now, again, for example, a rectal examination. As an old-fashioned doctor, I may insist on a rectal examination. But a young doctor, he may be quite satisfied with a 4D ultrasound, and he may say, this ultrasound gives me the information I want. I don't need to do a rectal examination. That's fine. So, but on the other hand, if you want a rectal examination to be done, at this point of time at least, you have to convert the teleconsultation into a physical visit. So in other words, you use your clinical judgment. Compliance, adherence, documentation. These are more important. The law permits you to charge appropriate fees for a teleconsultation. Whatever fees you charge in a face-to-face consultation, you can also charge. Of course, the guidelines don't mention about how the fees is to be collected. Today, there are so many methods, but a receipt can also be given digitally. So these are things which are very clear. The caregiver is deemed to be authorized on behalf of the minor or incapacitated patients. Now, here again, it is necessary that the identity of the caregiver and authorization should be checked. I'm again and again repeating, you need to use your judgment. If you suspect something, you have some reason to believe that this guy may not really be the caregiver, you have full authority to ask for an Aadhaar card, to ask for a photo card, and identify yourself. A doctor has the right to refuse a teleconsultation, A, before it commences, B, halfway through the consultation. In fact, I would consider it as malpractice if you continue with the teleconsultation, even though the bandwidth is dropped, even though the audio video is not there. You have every right to abort the teleconsultation on technical reasons, on clinical reasons. Whether you charge fees or not for this, of course, is an individual decision, what have you. Now, it is mandatory for doctors to prepare, maintain, and preserve the patient's records, meaning the history, the investigation reports, images, etc. To start with, what most of us have been doing in the earlier days for a long time, just as when I see a patient face to face in my OP records, I write down very briefly the history, the findings, and I must put down my working diagnosis and a clinical diagnosis. This is very, very important. It is most unfortunate that in 2018, the Mumbai High Court, the Honorable High Court, made an observation that a doctor prescribed drugs on a telephone without reviewing the patient's clinical status. He said that this was absolutely wrong, so which statement is true, and this was quoted out of context, and for a number of years, number of months, teleconsultations fell down. I repeat, it is wrong to give prescribed medicines on the telephone unless you have made a working clinical diagnosis. For example, I may even say NYD headache. That's fine. That means not yet diagnosed headache, which means I take the responsibility. When I say NYD headache, it means, in my opinion, clinical opinion, the headache is unlikely to be due to a brain hemorrhage, unlikely to be due to a brain tumor, unlikely to be due to meningitis, and so on and so forth. Acute abdomen. Now, acute abdomen itself is a diagnosis. It means that it is incomplete. You don't know the cause of the acute abdomen. Now, if you prescribe antispasmodics and analgesics which will mask the pain in a person with acute abdomen. Obviously, that is totally wrong. On the other hand, if you have done a video consultation and through reasonable virtual means, you are reasonably satisfied that though historically it sounded to be an acute abdomen, when the hand was placed on the abdomen, you do not think it's an acute abdomen, you certainly can prescribe whatever medical therapy is indicated. So do not prescribe any medicine. And the worst thing which can happen is, just because somebody has been your patient, I have made this mistake so many times, now not only through teleconsultation, but even through clinical practice. 10, 20, 30 years ago, I made this mistake. Nothing prevents a person who had tension headache, who had a so-called psychosomatic headache, whom you have been putting on antidepressants and tranquilizers for the last 1 year. Nothing prevents that person from developing a brain tumor headache. So please do not repeat the prescription just because you have been treating somebody as migraine. A migrainous patient can also develop an aneurysmal bleed. You need to examine the fundus with an ophthalmoscope. At present, you do not have methods to examine the fundus of a patient. Therefore, you must say, I cannot do a teleconsultation. I am suspicious. I'm not very certain that you continue to be depressed and you may be having something. So please go and see the nearest doctor or come to me physically. So again and again, I'm emphasizing that teleconsultation, you can do anything provided it is in the interests of the patient. Now, prescriptions. There is still some difference of opinion here. Encrypted digital signature. For all practical purposes, I don't want to go into the details of what is an encrypted digital signature, class 1, class 2, class 3, whether you must get it from this company, that company, etc. We'll come to that later. Right now, the practice guidelines state that you sign a prescription physically as you normally do, take a photograph of it and the JPEG image of that, or you can scan the photograph and electronically send a physical prescription to the patient, who can download that prescription in his phone. And today, the latest rules, the pharmacist has to accept a prescription digitally displayed on a smartphone, a tablet, or whatever it is, etc. A printout of a digitally displayed prescription is also valid and acceptable. Here again, there are several limitations. The law, very rightly so, prevents you from prescribing certain drugs which are too dangerous, which are habit forming, which are under various schedules, etc. However, in view of the pandemic, the list is a little more flexible than it used to be earlier. I don't have time to go into all the details. I advise you to please read everything. You will be able to understand what you want. List O, which is over the counter. List A, this scope is restricted to video consults. I've already told you that you cannot prescribe a drug on the telephone without having seen the patient or seen the patient again. Just because you saw the patient 6 months ago or 4 months ago does not allow you to refill the prescription. What about chronic diseases, diabetes, hypertension, asthma, and there are dozens and dozens of diseases where you have to be rheumatoid arthritis and so on and so forth. Clinical judgment. I expect the doctor to know that certain drugs cause renal function dysfunction, liver function dysfunction. You're a young lady, she could be pregnant, drug interaction. We expect a doctor to be absolutely professional about it, and you decide whether in that particular case it is safe to give a prescription without looking at the liver function test, renal function test, and so on. So this presentation will also be available. So those of you, please go through this. I don't have time to go through each one of this. This is the sample suggested by the Medical Council of India. But again, they've been extremely liberal. It is not mandatory. It is only a suggestion. But again, common sense tells you that when the government says it is a suggestion, it's a very polite, diplomatic say, you jolly well follow what I'm telling you as a suggestion. So please follow these instructions, write the diagnosis. It is criminal, in my opinion, to give a diagnosis, to give a prescription without a working diagnosis. It may be an incomplete, it may be the wrong diagnosis, but nevertheless, you have to give a diagnosis before you give the prescription. And please give the prescription in great detail. Now, exclusion. So far, I've very quickly covered. It will take hours to go through this 51-page guideline in detail, but I think you have a reasonable idea of what the guidelines is all about. Another thing which is equally important, the guideline does not, at this stage, this is 1.0 of the guideline, it does not specify anything, does not talk anything about hardware, software, infrastructure building, maintenance. Of course, it does mention that the platform provider is responsible to know about the authenticity, whether the RMP, the registered medical practitioner, is a genuinely registered with the medical council. Again, unlike the laws in Europe, unlike the laws in many other countries in the world, the Indian guidelines unambiguously state that if there is a violation of patient privacy due to a technical defect, the doctor cannot be taken to task. It is a platform provider who is completely responsible. Let's say a virus comes, the antivirus software has not been updated, my records are lost, something like that. The platform operator takes the responsibility. Of course, maybe the doctor cannot wash his hands off, but nevertheless, the platform operator plays a major role. Another interesting point, I'm sure some of you recall a few months ago in the state of Gujarat. It was the first in Asia, one of the very few in the world, where a doctor, I just forgot his name, a doctor in Gujarat did a robotic angioplasty, where he was able to remotely do an angioplasty. This today is against the law. The law very clearly says that digital technology cannot be used for any surgical or invasive procedure remotely, which means I cannot do a teleendoscopy. We at the moment are doing in our emergency Himachal Pradesh PPP, we are doing telecervical cancer screening, where colposcopy is done. Of course, this is done by a qualified nurse with the guidance of an obstetrician gynecologist from Madras. The area is a little gray. I myself am not clear. We need to get legal opinion whether in public interest we are allowed to do a colposcopy by a trained nurse. Now, again, the guidelines are not clear on whether consultation can be provided outside the jurisdiction of India. Now, the Pan-African Network project was initiated by the Ministry of External Affairs, Government of India, where we used to give teleconsultations to 42 countries in Africa. Of course, the project at the moment does not exist, but whether that is legal or not, only we need to clarify. So, concluding the first part of my talk, ladies and gentlemen, I as an individual, you could have seen this from the way I'm presenting this, I'm absolutely fascinated. I'm absolutely, I think it's just wonderful. This is what many of us have been fighting for the last 2 decades. This is a revolutionary point in the practice of modern medicine. It is sad that COVID-19 was required to do this, but in my earlier lectures, I always used to talk of BC. I used to say that I'm the last neurosurgeon in India who was trained in the BC era. I used to refer BC, before computers and before Christ, as one and the same. Today, ladies and gentlemen, I still think that the telemedicine era can be divided into BC. Here, the BC refers to before Corona and after Corona. So before Corona, telemedicine is one thing, and after Corona, telemedicine is totally different. Patients' interests have also been protected. As doctors, it behoves us to follow the law. As in any democracy, we will of course draw attention of the authorities to some ambiguities, lacunae, and requirement for amendments. We also need to be future ready. At present, the telemedicine guidelines insist that the final prescription or counseling has to be directly delivered by a registered medical practitioner, even if AI is used. There are several hospitals in India, including the Apollo group of hospitals, who are using AI in the management of diabetic retinopathy, predicting cardiovascular diseases and many other conditions. I wonder whether with the extreme use of IoT and robotics, human intervention role will become less and less. I wonder whether a decade from now, a malpractice suit will be filed against Google or against those who devised the algorithm. Again, ladies and gentlemen, please be rest assured that you do not run any increased risk by practicing remote healthcare. A test case is required. What has given guidelines? Yes, it may be the law, but all of us know, we have seen this so many times. A higher court overrules a lower court, the Supreme Court overrules a high court. A 5-bench decision of the Supreme Court is called for review by a 7-bench or a 9-bench of the Supreme Court. So nothing is written in stone. At the worst, it can be interpreted as a procedural lapse. And before I conclude this session, I would like to repeat again and again that no suo moto, it's very unlikely the authorities are going to take suo moto action for a procedural lapse, even if you inadvertently made some mistake. On the other hand, 90% of malpractice suits against doctors are filed because a patient is unhappy. You have antagonized the patient. The patient goes to court. The patient doesn't go to court because of an adverse result. The patient goes to court because of a very, very bad doctor-patient relationship. In 45 years of my practice as a neurosurgeon, of course, I have made mistakes. Of course, there have been errors of judgment, maybe major errors of judgment, but then I have never totally antagonized a patient, and no patient has gone to court. So, ladies and gentlemen, with all the technology at your hand, it's even more important that you practice tender, loving care. A happy patient is what is required. So all these rules are primarily to enable you to have a happy patient. And once a patient is happy, forget it, nobody is going to go to court. I could go on and on, but I think I will stop with this, and I will continue the second part of my talk. I have one more slide. This says that our universe has changed. India should no longer follow high standards. We should set them. We no longer should be striving to achieve world class. The world should strive to achieve India class. Nothing can stop an idea whose time has come. The time has now come. Creating awareness and convincing society that geography has become history should be followed. Now it is time for laws, rules, regulations, and compliance. So technology, the story of technology will always continue. So thank you, coronavirus. We are going to beat you, even though you are responsible for a lot of this. As Winston Churchill said, never, ever let a good crisis go to waste. Confucius remarked 2,000 years ago, the journey of 1,000 miles begins with the first step. I don't think we have taken the first step. I think we are several miles into it, but we have a long, long way to go. And I'm sure that all of you are going to be ambassadors of telehealth and see that telehealth no longer is in the outskirts of healthcare, but becomes an integral part into the core of the healthcare delivery system. I'm going to spend the next 10-15 minutes on the application of telehealth today. This slide, prepared just 2 hours ago, shows that India has, as per this particular World Health Organization recognized chart, 5,095 slides. The print is too small. I'm not able to read it. I think it's about 1.35 million people have been affected with the coronavirus, and 73,000 people have already died. So obviously, it's important that we need to practice telemedicine. COVID-19, or the coronavirus, has in a few months transformed life on this normally peaceful planet. The consequences of coronavirus is not due to the strand of RNA. It just has 30,000 adenine, guanine, cytosine, thymine, uracil alphabets. This strand of RNA is pulverizing the whole world, not because of its biology per se, but because of the massive global measures being deployed to contain its rapid spread. Global economy is taking a toss, and I don't know whether we are seeing the end of it or only the beginning. Why is telehealth so important in coronavirus? Now let's spend a little more detail. Triage. It is very, very important that the government has been repeatedly telling, the media has been shouting this ad nauseum, stay at home, stay at home, stay at home. How can one get medical care when you stay at home? Yes, you can get, assuming that you have a reasonably good internet connection. So tele-triage. Now, nothing prevents a person who has got cough and cold. He need not have coronavirus, but he could be having another type of pneumonia. He could be having some other respiratory infection. He could be having a COPD, chronic obstructive pulmonary disease. People with diabetes, hypertension, immunocompromised, post-cancer, post-radiotherapy, and what have you are highly susceptible. An elderly person is highly susceptible. So we can, through the telephone, through a good algorithm which is available with you, with a very high level of sensitivity and specificity, decide on which person should physically go to a hospital, and if he should go to a hospital, where exactly he should go to the hospital. Now, what is the exact meaning of the word triage? Triage can be described as a process of deciding which patient should be treated first based on a degree of sickness or severity of injury. As on 9th April, we have not yet reached this stage. We are all praying to God, and hopefully the measures taken are so fantastic that we will be able to flatten the curve. Personally, I somehow think we are not going to make use of the thousands of beds which have been set apart, the hundreds of ventilators which have been set apart. This is what we want. But in the very, very unlikely event that we do have this is what you need to practice, and you need to effectively decide on which patient needs a tele-triage. Now, telephone triage is a process by which a trained clinician can identify a patient's problem, estimate the level of urgency, and render relevant advice to the patient over the phone. Today, this extends to the use of various connectivity options, including video, multimedia, remote tests, and software application. Chatbots have already been used by at least 40 to 50 hospitals in this country. Now, of course, this form was made about 2 weeks ago. Perhaps the form changes now. So every few days, the government is releasing a new method of doing a self-triage. Now, the ASHA, or the basic health worker, can evaluate the patient remotely using an approved flow chart or algorithm in the local language using the existing tablet. All of you know that 650 million Indians live in so-called rural India, where you certainly don't have secondary and tertiary hospitals. 95 of India's ID specialists, infective disease specialists, live in the state capitals and the metros. However, India is a paradox. We already have reached the 1 billion mark so far as mobile phones are concerned. 40% of them are already smartphones. So this ASHA from the remote end, using an algorithm, can effectively communicate, not with a doctor, can communicate with a trained paramedic who will help the ASHA do the initial filtration and the screening. The trained paramedic in a tier 2, tier 3 city or even a metro can, if necessary, escalate the case to an MBBS or even MD general medicine. And if it's a particularly difficult problem, the MD general medicine can escalate it to somebody with much more experience. All this can be done remotely. Telemedicine is a safety valve for a strained healthcare system. Virtual visits are the best way to decide who needs to be tested for COVID. It's impossible. Even if the government makes 100,000 tests available per day, never ever forget that every sixth human on this planet is living in India. With 1,350 million people, people can argue, but it's just not possible to do tests for asymptomatic. Forget asymptomatic, even symptomatic people, it's never ever going to be possible. Therefore, we need to filter, we need to do a triage remotely. So this is one of the ways in which COVID-19 pandemic can be controlled. Automated screening algorithms with local epidemiologic information. The brilliance of artificial intelligence is that we can customize these algorithms. The Nizamuddin Delhi, if somebody is coming from Nizamuddin Delhi, he'll be given more weightage than somebody who is in Lakshadweep or the Andaman and Nicobar Islands. If I am 70 years old and I have diabetes, hypertension, a cancer, I'm already being treated with chemotherapy, obviously the weightage will be more, and so on and so forth. All this is very simple, and this can be deployed at the remote test end. Most countries have a shortage of healthcare providers, and if they themselves need to be quarantined it would lead to a disastrous situation. Not necessarily, not if there is telehealth. I am a doctor, I have been quarantined, I'm not allowed to go to the hospital. But my mental faculties are absolutely normal. I have a good internet connection at home. I know all about this. So I can tele-evaluate 1,000 people, if not 1,000, at least 200, 300 people. So every healthcare provider who is quarantined today, I don't know whether this is actually being done. This morning's TV, I read that in Wockhart's Hospital, 86 people have been quarantined from Wockhart's Hospital. These 86 people, each one of them could remotely evaluate at least 200 to 300 people. Very simple evaluation. So please remember, telemedicine is very, very useful, particularly in a pandemic situation like this. Health education, with a click of a button, it is possible through not only through multi-point video conferencing, through various, today we have so many platforms, various YouTube channels. I'm told with certain YouTube channels, you can even reach across to 10,000 people at the same time. With multiple methods, you can show videos, animations, clippings to millions of people, not just a cough, which you are now given over the telephone. So use of technology for all these purposes. Now, the telemedicine should be a national strategy. Of course, telemedicine has been repeatedly mentioned, and again, it's a great compliment to the government that within 10 days of the MCI notifying this, the Department of Ayush has also notified. Telemedicine guidelines have been given by the Department of Ayush. Ayurveda, Unani, Siddha, homeopathy is not covered, but these three are covered, and similar guidelines have already gone. So you can see here, telehealth alone will be effective, and this will help preserve the critical healthcare provider. All stakeholders in the system, whether private hospital, laboratories, or what have you, must need to embrace telemedicine. So far, I've been giving highly theoretical lectures. It's very easy to talk about all this, but then telemedicine units cannot be brought overnight. There are challenges in introducing telemedicine. But the good thing is we have hundreds of telehealthcare providers who have been in this game for many, many years. And I'm sure every one of us would be happy to handhold you, would be happy to tele-mentor you. The Telemedicine Society of India has already started a major program where FAQs are being answered by the hundreds. Negotiate coverage with payers. Now, I am convinced that so-called free teleconsultations, so-called philanthropy at the best can hold for a few days. It is not a dirty word. Making profit should not be considered a dirty word. Of course, it should be reasonable. You should at least get back what you are spending. And somebody has to pay. If the patient cannot pay, the insurance company has to pay, the government has to pay, and so on and so forth. So negotiate coverage with payers, public-private partnership with state governments, persuade insurance companies, whatever it is. But unless you generate revenue, the telemedicine unit's obituary will have to be written very fast. So please look at it from a revenue-generating point of view. Today, as I showed you in one of the earlier slides, fever, cough, shortness of breath, every one of them can be evaluated remotely. I can look at your oxygen saturation. I can even predict with an uncanny precision what is your pulmonary reserve. We in Apollo Hospitals, Chennai, when necessary for COPD at a height of 14,000 feet, we have been doing various tests, pulmonary function tests, spirometry. Today, it's not too expensive. Telespirometry can be done. I know every single clinical detail which is required in a suspected case of coronavirus can be done remotely. Digital stethoscopes not only transmit lung and heart sounds. This is simple. It's an audio file, 40 kb, 100 kb. The transmitted audio file can even have a description of the sounds. And just like you have a semi-automated ECG, the heart sounds and the lung sounds also will come with a semi-automated description. Blood pressure, pulse rate, respiratory rate, all this can all be monitored remotely. It's just a question of deploying technology. It's very important that we do not trust our memory. You have algorithms, charts like this. So simple to have these charts. Give it to everybody. Give it to an ASHA. Fever is common. It's rare in common cold. It is common in flu, but remember, it is not at all common in the common cold. Shortness of breath is much more common in COVID-19 than in a normal flu. Aches and pains and so on and so forth. So all this can be done. Again, there are so many algorithms like this which gives you very clearly green, yellow, red. Of course, the contact history may after a few weeks become less important once transmission occurs from within the community. Just because I do not have a travel history or a history of a direct contact does not exclude me from COVID-19. Nevertheless, the weightage will be given depending on which part of the country you're coming from. So all this can be transferred digitally. So what is the way forward? I'm sure all of you remember a couple of years ago, the government said we are going to have multiple AIMS and multiple IITs. When I was a medical student, there were 4 IITs in the country. Today, I think there are about 25 or 30 IITs. There are at least 15 All India Institute of Medical Sciences. Ladies and gentlemen, the time is now opportune. When I passed out, there were 110 medical colleges in the country. Today, there are 465 medical colleges. Every 2 weeks, a new medical college is coming somewhere or the other. We have 700 district hospitals and at least 1,000 secondary to tertiary hospitals situated in the metro, state capitals, tier 2 and tier 3 cities. It is, if you can build a hospital, if you can build a medical college once a month or twice a month, I see no reason why you cannot have 100 or even 500 telemedicine units every day. It's all a question of the mind. The situation warrants it, and I do hope we will exploit, capitalize this situation. And I look forward in my lifetime to reach the day where telemedicine is no longer considered a subspecialty. We don't talk of the Stethoscope Society of India. The stethoscope, of course, now the stethoscope is dead. Today we use pocket-shaped echocardiograms, but whatever it is, telemedicine should not be considered a subspecialty. You should not require mad people like us to propagate telemedicine. Telemedicine should be an integral part of the health core of the healthcare delivery system, whether you be a pediatric cardiac surgeon, whether you be a fetal surgeon, whether you be a public health specialist, an epidemiologist, what have you, there is a definite role for remote healthcare. I do hope that we understand this and we make use of this opportunity. Digital health, ladies and gentlemen, is bringing out a real revolution. It is shifting the point of care to where it should have been all this time. The patient's abode, not the hospital. The point of care should be shifted from a quaternary care hospital to the patient. Today, it is possible to have a hospital in your pocket, a doctor in your pocket, a laboratory in your pocket. Awareness must be raised among patients about the benefits of telehealth. Technology acceptance and a behavior modification strategy should be considered. Even in 2020, in the United States, 88% of companies with 500 or more employees offered telemedicine as part of their health benefits. However, only 9% of eligible employees used it. This is not surprising. For 5,000 years, ever since the first doctor-patient face-to-face relationship started, it has always been the doctor physically touching you. In a couple of years, or even much earlier than that, the haptic sensation of touch will come. And I'm sure by wearing cyber gloves and using my mouse, I will be able to remotely palpate a multinodular goiter and decide whether it is solid, cystic, or calcified. But till such time, the healing touch which the doctor gives has to be through your own personality, how you react with the patient. Ladies and gentlemen, I cannot help but be a salesman. My last slide, a humble request to every one of you. Please tell all your friends. The Chairman, Board of Governors of the Superseded Medical Council of India has invited, not invited really, mandated the Telemedicine Society of India to ensure that 500,000 doctors in India become sensitized, oriented to the practice of telemedicine. A wonderful group of people, about 60 of them have worked night and day, 14 hours a day for the last 10 days, and have put together a fantastic module, 3 modules, 20 minutes each with 1 hour for FAQs, video, question and answer session done totally free of cost. This is done twice a day, and we will be reaching out all of you. Medvarsity has very kindly promised to help us do this, and on behalf of the Telemedicine Society of India, may I request each one of you to please, please, please just spare 120 minutes of your time. 2 hours when you are going to live till 85 or 90 is an insignificant part of your life. Believe me, you will be the better doctor by spending these 2 hours, and you will teach the Telemedicine Society of India what to do, what not to do. Telemedicine should be an integral part of everyone's healthcare. So let us exploit this situation, not just to provide healthcare for the next couple of weeks, but to ensure that all our patients in comfort. Just imagine right now, from 24th of March till today, there has not been a single death as road traffic accident in Chennai. Unbelievable. The number of road traffic accidents have come down 95%. The pollution has come down. We are able to see the Himalayas from 200 kilometers distance. Why can't we provide health care without your physically having to go search for a car parking place, spend valuable oil, pollution, that, this, etc. You're all too educated, too intelligent for me to tell you all this. So please remember that remote healthcare can definitely be not just a substitute, and as the Americans call it, this is going to be the new normal. 20 years from now, ladies and gentlemen, it will be a rare person who physically, why 20 years? 10 years from now, it will be a rare case when a person goes to a hospital, probably to get a heart transplant done. Thank you once again. If there are any questions, I'll be happy to take them.
Thank you very much, sir. Hello.
Hello.
Yeah, Dr. Ganapathy, thank you very much, sir. So there have been a lot of questions from the audience which I have been noting down. So the first question was, what about the doctors from homeopathy or Ayurveda, whether they can practice telemedicine? How can they provide care?
At the moment, as of today, telemedicine is legally allowed for Ayush. That is Ayurveda, Unani, Siddha. Homeopathy, as of today, or yesterday rather, is not covered. But I think it's a question of time. In a week or 2 weeks, maybe homeopathy also will come under the act. So certainly Ayurvedic doctors are here, and we would like some volunteer from the Ayurvedic fraternity to please contact us. The Telemedicine Society of India would be happy to design a course exclusively for Ayush practitioners as well. We treat Ayush practitioners as our own fellow brethren, and there is no difference so far as the TSI is concerned between an allopathy doctor and other. We don't think the word alternative medicine is correct. In fact, Dr. Pratap Reddy several decades ago mentioned that he said in several conferences outside India that it is allopathy which should be considered as alternative medicine.
Thank you very much, sir. I think that answer, I think, has been given to all the people who had the question. So the second question is it advisable to give telemedicine consultation to infants and newborn? I think that was one of the questions which was asked.
Sorry, the person asking the question either was not listening or I was not good enough to make my presentation clear. Sir, the answer is clinical judgment, clinical judgment, clinical judgment, clinical judgment. There is no yes or no answer. If you are confident that you can give an answer for the unborn baby, for a baby born 1 hour ago, go ahead and do it. Generally speaking, I would assume that I, for person, would not. I have given a neurosurgical teleconsultation for a 2-hour-old baby. The baby was born with hydrocephalus and had a meningomyelocele. So for a 2-hour-old baby, I have given the correct teleconsultation. It depends entirely on your confidence of handling it.
Okay. So one more question is there any consent form to be obtained from the patient in a telemedicine consultation?
If you recollect what I had said, I think it's a 10 slide or 11 slide, the practice guidelines very clearly state that if the patient initiates the request for a teleconsultation, no specific consent form is required. It's an implied consent. When a person comes to me, to my outpatient, to room, to my chambers for a consultation, I do not get a consent form from him. However, if the consultation for a patient is through a doctor or through a healthcare provider or somebody else, then consent form is required.
Thank you, sir. So one more question which has come up is whether it is advisable to keep a physical record parallel to the digital prescription by
Yes,
the
very
doctor.
good. Yes, it's always advisable to keep a physical record. We all know suddenly your antivirus software may not be up to date. Anything can happen. Files can go corrupt. It's always advisable.
Yeah. Hello. Yeah, hello. So, if you are keeping a physical record, then how long the record has to be kept is another follow-up question.
Right. I presume the same rules with the current rules, if I'm right, is 7 years. There are no special
Okay.
rules for telemedicine record. See, we have yet to reach that stage. Please remember the rules were notified just 12 days ago. So all these questions which you are asking, we will make a note of it and we will represent to the authorities and ask for clarifications. Please ask us these questions. Only then we will know what you want.
Okay. So one more question is come up is how to, I mean, give a consultation to a person who is not the patient, but who is come on behalf of a patient, a
Yeah.
proxy patient.
Correct. The rules very clearly mention that, and I had also elaborated this in my talk just 30-40 minutes ago. You need to be absolutely sure why the so-called surrogate or why the proxy guy is why the patient can't come in front of you. So you must be convinced on that particular case that for example, the nearest internet connection is not available. It's a bedridden patient. It's confined. He's in the 7th floor. It's a bedridden patient. There is no internet connection there. Internet connection is only somewhere else, and there are etc. etc. You need to be convinced why the patient cannot come to you physically. A. B. You need to be convinced of the legality, meaning that the proxy person asking for the consultation is legally empowered to ask for it, meaning it's a spouse or son or daughter or brother or cousin or somebody. Employer generally, no, generally it has to be a first a very close relative. So you need to be convinced of that. 3, you need to be convinced that the records, it's very dangerous. You need to be convinced that the records, which this is called an asynchronous after a consultation, so store and forward as you call it. So you need to be convinced that the records which you are perusing and based on which you are going to give an opinion is really the record of the person to whom this opinion is being mentioned. Number 4, you need to write down all this in great detail. That's what I would do, that I am giving an opinion to a proxy who is the patient's son, daughter, etc., 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 because the patient is unable to come for the following reasons: 1, 2, 3, 4, 5. In view of these extraordinary special circumstances, and because the previous medical case records very clearly indicate that he was operated 15 days earlier or 1 month earlier or whatever it is. In other words, there is no doubt about the previous diagnosis. So I would not give an opinion to a proxy when I'm uncertain of the diagnosis, when I have not seen this patient earlier. Suppose it is my own patient whom I have seen earlier. I know all about the patient, and I know this now is a genuine reason why he is not able to come. There's a power failure in his house. It will take 24 hours for the power to be restored. Something genuine. So you have to use your common sense. At the end of the day, you need to be convinced that what you are doing is correct. That's all these medical practices, please take it in the spirit. Now, don't go by every single letter and how you interpret it. It is the spirit that is important, not the individual letters.
Okay, so there's one more question, Dr. Suganti Iyer from Mumbai. So what she's asking is, any specific penalties for breach of guidelines as it is annexure to the Code of Medical Ethics?
Yes. So this has also been mentioned that there are no increased penalties just because your consultation is virtual. There's only 2 or 3 lines in passing which mentions whatever are the current rules in regard to a face-to-face encounter, the same will be decided on. In other words, a breach of the telemedicine practice guidelines is sufficient for a patient to report you to the local state medical council. The local state medical council will take cognizance of this report and do whatever they would normally do when it is a complaint is brought to them in a non-telemedicine milieu. So whatever they do, so the punishment also would depend on that. It could be that they say no, the complaint itself is frivolous. It could be that they, as they could warn you, they could censure you, they could prevent you from practicing for a few months, they could strike you off the rolls, etc., etc. So there are no special rules for telemedicine. Whatever it would have been the stand adopted by the medical council for a face-to-face consultation will apply for remote healthcare also.
Okay. One more, Mohit Bansal. He's asking how to register with the Teleconsultation Society of India.
Oh, wonderful. You have made my day today. Please go to tsa.org.in, Telemedicine Society of India. The forms are there. I didn't tell you, but then it would be misinterpreted as a salesman. I'm not a salesman. I'm only a past president of the society. Please, all the 450 or 500 or how many people are listening to this, please, the very fact you are listening shows you have some interest in telehealth. You will make your position much stronger. Once you become a member of TSI, you are legally bound to protect you, to do what you think, we'll advise you. There are so many things. And of course, the strength of TSI will become more because we will be more representing what the community of remote healthcare specialists want. So please do enroll as a member of TSI and also join this 2-hour orientation program.
Okay. So I think one last question. I think the digital prescription which is served through telehealth, whether it is valid, that is what the question is.
Yeah, I had addressed this also. The guidelines, in some places, some amount of ambiguity is there. But generally speaking, as I told you very clearly, you must follow the MCI guidelines, which means the name of the doctor, the registration number, the medical council in which you're registered, name of the patient, age, sex, the diagnosis. This is very, very important. Diagnosis could even be very simple. It could just say jaundice. Or it could say jaundice secondary to carcinoma, gallbladder, ascites, that thing, hypertension, diabetes, etc., etc., etc. So diagnosis must be written there. The certain drugs at the moment, please go through the slides once again. Certain drugs are you are not allowed to prescribe remotely. Certain drugs for the purpose of the epidemic, you are allowed to prescribe. Certain drugs you cannot prescribe unless you have done a video consult, and that too within 6 months. Telephonic consultations, you can prescribe certain types of drugs. How the prescription reaches the pharmacist, every one of them, if anybody is interested, just send us a mail. We will send you a copy of the 51-page document that very clearly states what drugs can be prescribed, what cannot be prescribed, etc. How it is to be prescribed. I had mentioned this half an hour ago. You write out a prescription as you normally would do and scan it or take a photograph of it and send it to the patient. Patient can either take a printout or he can even show the digital display. The government is so forward, they have even said that the digital display of a prescription with the doctor's registration number, signature, etc. on a screen, whether it's tablet or smartphone or what it is, the pharmacist is bound to dispense the drugs.
Thank you, sir. So one more question is, in India, how can you reach the unskilled community in the remote and the rural areas? And it seems to be very interested.
Very important. I mean, very easy. Just contact me along with 500 other people. I'll ensure that you reach at least 100,000 people. We have a couple of projects where we are not able to escalate it, or not purely because we don't have fantastic volunteers like you. We want people like you. Please do contact us, and we'll give you several opportunities to show your innate leadership skills.
Okay, so one interesting question. Can a physiotherapist also do teleconsultation in India?
Good question. We will note it down. As per the guidelines notified on March 25th, these guidelines are applicable only to registered medical practitioners, registered medical, underline the word medical, practitioners registered with the State Medical Council or the Medical Council of India. Now, having said that, we do telephysiotherapy for several public-private partnerships where the chief physiotherapist, a very, very senior physiotherapist, advises or guides a younger physiotherapist, a qualified BPT, a qualified bachelor in physiotherapy, located in a remote place on how to do it. So I don't see anything illegal, provided there is a medical doctor must primarily take charge. Now, for example, I am a neurosurgeon, patient with a paraplegia, quadriplegia, hemiplegia, whatever it is. I've treated the patient, everything, discharge, and then I have advocated physiotherapy. Now, obviously, a neurologist, neurosurgeon is not going to do the physiotherapy. So long as the prescription for physiotherapy is given by a medical doctor, and the physiotherapist also advises the patient periodically. So you physically go to the patient's house, give physiotherapy once a week. The remaining twice a week, you probably do it remotely. I really don't think it can be construed as any violation of any law. I don't think there is any specific law which says it is legal. But then we have been practicing telemedicine for the last 20 years without a law which said it is legal. The bottom line is, in the patient interest, don't do anything which will make the condition worse. A physiotherapist is certainly not empowered to give physiotherapy without a final diagnosis having been made by a registered medical practitioner, and a registered medical practitioner must tell the physiotherapist, do this type of physiotherapy, don't do this type of physiotherapy, etc., etc., etc.
Okay, thank you, sir. Ms. Bhavna, so she has a question that, can we get a copy of the list of drugs which can be prescribed during a teleconsult?
Most of it is available in the MCI website. I'm sorry, I'm not a pharmacist or a pharmacologist. No way I can. Let me try. Just send the mail to us. Let me ask some of my colleagues if it is possible to get it. Let me ask the TSI if it's possible to get it. If it is, we will definitely revert to you. But I think a more useful thing would be, you can get it for us, and we will be quoting your name everywhere that this was got to us from you. So why don't you please go to the website? Everything is available in the URL. Please go to the MCI website or the pharmacy, the appropriate website. I understand some guideline was passed a few days ago regarding e-pharmacy, e-prescription, etc. So may I, on behalf of the TSI, request you to please do it for us and send us a copy. That will give you enormous knowledge and help all of us also.
Okay, I think somebody has given the answer also in the chat. Sir, one last question, perhaps. I think this would be the last question because I don't see any more questions coming up. I think you have already answered this question, I think. Is digital signature mandatory on the prescription? So I think...
Yeah, this is a little controversial. It's not mandatory. Okay, I can answer it. It is definitely not mandatory. The guidelines in one paragraph mention about digital signature. What I have understood the term digital signature to be is, it's a encrypted signature which can be authorized class 1, class 2, class 3, which can be obtained only from companies approved by the government of India. And the digital signature is issued for a specific cause. If for a prescription, it can be used only for prescription, etc. But eventually, that's what is going to happen. But right now, the transition period, I think a scan or a JPEG image or photograph of a physical prescription is good enough.
Thank you. Since I don't see any more questions, yeah, I think that's about it, sir. I think I don't see any more questions. I think most of the questions which you have already answered are the same ones. So I think we are now conclude the session. So I take this opportunity to thank Dr. Ganapathy for taking his valuable time out from his busy schedule and educating and throwing light on this very important topic of telemedicine, and especially the role of telehealth and how technology can be used in the current scenario to manage this COVID-19 pandemic. I'm sure there was a lot of takeaways, key takeaways for the audience who have taken their important time also and attended this. And I'm sure it was a very enriching experience for all of us. Thank you, Dr. Ganapathy, once again, and uh, a very good day to all of you. We will send you uh, the presentation after consulting with Dr. Ganapathy. Thank you, sir. Thank you very
Thank
much.
you,
And
Srinivas,
thank you,
and
audience.
thank all the attendees for their valuable time. Please keep in touch. Any questions you want to ask, you are most welcome to ask us.
Thank you, sir.